I'm retina physician. Um, my name is Mari Rodriguez, and I will be your host today. I am a retina specialist with Vitreoretinal Associates, and I practice in Massachusetts, and I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. And we would love to hear your thoughts online. You can follow us on Facebook, LinkedIn, YouTube, and Twitter. And you're also welcome to write on the chat and share your thoughts with us during this event. So today we'll be discussing what I think is a very interesting case. This 35-year-old gentleman presented to our clinic for evaluation of peculiar fundus findings during routine examination by an outside provider. He had no visual complaints. His visual acuity was 20/20, and he had normal intraocular pressures. The anterior segment exam was unremarkable. Examination of the posterior pole demonstrated bilateral, narrow, irregular lines deep to the retina and radiating from the optic disc. These lines were more strikingly evident on fundus autofluorescence, which we can see here, the fundus autofluorescence, where they appeared as radiations from a ring-like area of mixed peripapillary hypo and hyperautofluorescence modeling. So, of course, these lines represent angioid streaks, which result from breaks in a weakened Brooks membrane. And when we see angioid streaks, we need to think about the systemic associations. And the Pepsi mnemonic comes to mind, and that stands for P, pseudoxanthoma elasticum, E for Ehlers-Danlos syndrome, P for Paget's disease of the bone, S for sickle cell disease and other hemoglobinopathies, and I for idiopathic. So a general management strategy for patients with angioid streaks is determining if there's any underlying systemic associations present and if any secondary ocular complications exist that warrant the treatment. So complications include the development of choroidal neovascularization, secondary to a weakened Brooks membrane. And this is usually treated with anti-VEGF therapy. These patients are also more susceptible to choroidal rupture in general, and so they should be encouraged to wear rigid eye protection and to prevent blunt trauma to the eye. So of these systemic associations, pseudoxanthoma elasticum is the most common of these systemic associations. And I would like to go back now to the initial fundus image of our patient and then notice something else here. So temporally in each of the eyes, there are pigmentary changes that are known as peau d'orange. Additionally, we looked at the patient's neck and then we noticed that he had these small yellowish papular lesions, as well as some cutaneous laxity around that neck area. So pseudoxanthoma elasticum is caused by autosomal recessive mutations in the ABCC6 gene. And the disease causes mineralization of elastic fibers in some tissues. So besides the skin and the retinal problems that we already discussed, other complications include the development of early atherosclerosis, and also gastrointestinal bleeds can occur. So we have a high suspicion for diagnosis of pseudoxanthoma elasticum in our patient, and he is pending a skin biopsy with dermatology to arrive at a definitive diagnosis. Again, thank you for tuning in today. You can leave us a comment online via our multiple platforms, and we hope to see you again in about a month as we discuss another interesting case. Thank you.